The task assigned to me is to talk on a very important stage of a woman's life, especially her reproductive health, which is menopause, and its impact on how these hormonal shifts can have an impact on her sexuality as well, especially when you talk about a woman with diabetes. Now we know that changes to the woman's reproductive cycle are part of her normal aging process, which also involves reproductive aging. So, the physiology of the reproductive system we know is regulated by an interplay between hormones from the hypothalamus, which governs everything, sending signals to the pituitary, which in turn have an impact on the ovaries. So, to make things very simple, we understand that the gonadotropin releasing hormone from the hypothalamus stimulates FSH and LH release from the anterior pituitary. FSH is responsible for follicular growth and estradiol synthesis, and LH is responsible for ovulation as well as luteal progesterone production. So, what and eventually the estradiol, progesterone, and inhibin they exert a feedback inhibition on the pituitary and hypothalamus. Now, as women age, approaching their 40s and 50s, ovarian function starts declining with major alterations in this entire hypothalamo pituitary feedback mechanism. So, what eventually happens is as she ages, a female child is born with almost 1 lakh, 1 million ovarian follicles. And as the child grows, eventually there is follicular depletion that happens. So, eventually, by the time she's nearing menopause, what happens is there's a depletion of these ovarian follicles. So, there is a reduction in the ovarian function, there's reduced estrogen production, and desensitization of this feedback loop which happens. Now, menopause results from a reduction in the ovarian production of these hormones, which is essentially estrogen and progesterone. As a result, a state of relative androgenicity is created due to a reduction in the sex hormone binding globulin production by the liver as well. So, as you can see on the screen, there's a natural decline in the hormonal production as a woman nears menopause. So, to make the physiology very simple, like I said, compared to fetal life, when there are almost 1 to 2 million ovarian follicles present, by the time a woman reaches her menopause, follicles have declined to almost less than 1,000. And the rate of loss is actually accelerated after her mid 30s, where we consider that the reproductive functions have been completed, childbirth is over with, and that is when the fertility starts declining beyond the 30s. Now, like I said, as the granulosa cells are declining, there's a reduction in estradiol and inhibin B production. Now, inhibin B is responsible for suppressing FSH in the early follicular phase. So, as she's nearing menopause, inhibin B declines and therefore FSH starts rising. Now, estradiol also, like I said, declines and progesterone falls sharply. So, eventually, the cycles become anovulatory and there's no corpus luteum. AMH also is an indicator of ovarian reserve. So, as she moves towards menopause, there's a reduction in AMH, which almost becomes undetectable when she hits her final menses. So, like I said, there's loss of estrogen and the inhibin B feedback. FSH rises about 10 to 20 fold, and there's almost a threefold rise in LH also happens as part of the menopausal transition. Now, reduced estrogen means reduction in the hypothalamic inhibition. So, the feedback loop that I explained earlier. So, the gonadotropin releasing hormone pulse amplitude rises, eventually creating a state of androgenicity. Androstenedione, testosterone, DHA, DHES, all of them decline with age, creating a state of relative androgen predominance, which is responsible for the virilization symptoms that we see in a woman, especially the facial hair, etc. So, like I said, you can see it here in the graph. In the perimenopausal period, you will see a decline in the estrogens, the estradiols, and a slight rise in in the FSH. So by the time she hits menopause, you'll see FSH going up and the estradiol coming down, which is the menopausal transition or the physiological changes as she is approaching her reproductive senescence. And this transition continues, it may last for a number of years, starting somewhere around the late 30s or early 40s with unpredictable and variable fluctuations in circulating hormones. So pre versus post menopause, you will see estradiol from a premenopausal reproductive uh, levels of about 100 to 300 coming down to less than 30. Postmenopausal, progesterones eventually becoming negligible, FSH going up slightly, like I said, the LHF again going up a little, inhibin B becomes completely undetectable, and AMH also becomes undetectable as she hits her final menopause. So, the menopausal transition is characterized by distinct stages with different hormonal profiles and clinical implications. So, in the perimenopause, like I said, when the follicles are declining and all these hormonal shifts are occurring, it is marked by irregular ovulatory cycles, fluctuating hormone levels, reduced fertility, hot flashes, vasomotor symptoms. By the time she eventually hits her menopause, what you see is after menopause, hormonal changes resulting defined by sustained hypoestrogenism, primarily due to a 90% decline in the ovarian estrogen production. There's loss of the hormonal protection. I'll come to that in a little while, and increased risk of cardiovascular disease. Now, consequences of these estrogen deficiencies symptomatically may vary from perimenopause to advanced age. So, like I said, early 40s, when she's entering that perimenopausal transition, there are hot flushes, there's sweating, insomnia, menstrual irregularity, as well as some psychological symptoms. By the time she's in that intermediate age group of about 50s to approaching 60s, you'll see vaginal atrophy, dyspareunia, skin atrophy, urge stress, incontinence, and late menopausal after the age of 60. What you see is all the things associated with postmenopause: osteoporosis, atherosclerosis, coronary artery disease, cardiovascular, and Alzheimer's. All of them having an impact on her life. So, like I said, many organ systems may be involved, resulting in a wide spectrum of menopausal symptoms: altered physiology, night sweats, osteoporosis, cessation of periods, irregular heartbeat, hot flashes, and frequent urination. Then you have neurological symptoms: loss of libido, fatigue, dizziness, irritability, depression, and mood swings. You have pain, discomfort, breast pain, joint pain, vaginal dryness, headaches, digestive problems, dyspareunia, dysuria, as well as external manifestations in the form of itchy skin, dry skin, hair loss, brittle nails, and weight gain. Now, what is the connection between menopause, metabolic syndrome, and diabetes? Of course, the decline in the estrogen levels during menopause result in dyslipidemia, insulin resistance, central obesity, as well as inflammation. All of them we know are the fertile soil for metabolic syndrome, type 2 diabetes, and cardiovascular disease. So, menopause today is an accepted indicator for metabolic syndrome in women irrespective of their age, and central obesity, pathognomic of menopause, is characterized by increased visceral adipose tissue, contributing to the metabolic syndrome risk as compared to the general obesity. So, like I said, the protection, the cardiovascular protection provided by estrogen is lost as a woman reaches her menopause. There's weight gain, redistribution of fat to the abdomen, blood pressure rises, there's dyslipidemia, the LDL goes up, triglyceride goes up, insulin resistance comes in. So insulin sensitivity reduces, glucose becomes intolerant, and there's accelerated atherosclerosis. Now, diabetes per se also has an effect on the ovarian aging and menopause. So, in women who have late onset type 2 diabetes, because of the obesity and the premenopausal weight gain, you will see a later age of menopause in some studies in these women with late onset type 2 diabetes. On the other hand, in type 1 diabetes, we know it is an autoimmune disorder. So here you see an earlier ovarian aging. There's an increased risk of autoimmune destruction of the ovarian tissue as well, and adverse changes to the vascular endothelium, which result in subclinical vascular disease and later on a clinical vascular disease. So there's early depletion of ovarian follicles that may occur in women with type 1 diabetes. Now, like I said, different women will have a different spectrum of menopausal symptoms because, during the midlife, like I said, you have more of a vasomotor kind of a presentation. Almost 80% of women having vasomotor manifestations, which may last for almost 8 years. And then, of course, you have disturbed sleep, you have biological, psychological, behavioral, as well as social changes, which shape her midlife and future health. So, you may have a decline in the cognitive performance, there's depression, there's anxiety, and there's a decline in sexual function, which may be apparent as much as 2 years before her final menstrual period, and it slows thereafter. Now, like I said, there are changes in the genitourinary tissues during and after menopause, which may result in discomfort, pain during intercourse, stress, incontinence, as well as sexual dysfunction. The famous GSM, the genitourinary syndrome of menopause, which has an impact on her diabetes management as well. So there's an increased risk of infections. There may be medical medicine adherence also becomes very bad. Urinary symptoms may interfere with consistent medication routines. Glycemic control may worsen. UTIs, GTIs, common with a lot of with SGLT2 inhibitors, etc., especially enhanced in the postmenopausal women. So you need to be very careful. Clinical considerations: you need to look out for vaginal atrophy combined with diabetic neuropathy. It doubles the incidence of dyspareunia in women with diabetes. Like I said, urinary symptoms, frequency, urgency, and nocturia, they may disrupt sleep and daily routines. And of course, therefore, it has to be an integrated care model for women who are approaching menopause, especially diabetic women, because of a collaborative approach between gynecologists and endocrinologists has been shown to improve outcomes. And therefore, addressing the genitourinary syndrome of menopause is very important for comprehensive diabetes management, especially in the menopausal women. If you look at the pathophysiological mechanisms causing sexual dysfunction in women with diabetes, you will understand there's role of hyperglycemia, UTIs, vascular complications, and so on and so forth. But remember, low estrogen levels, which are a component of menopause, can affect vaginal lubrication. Estrogen deficiency can also manifest as a poor general condition. There's loss of interest in sexual activity, fatigue, depression. Androgen deficiency also plays an important role in the pathophysiology of low libido in women with diabetes. So, sexual dysfunction per se in diabetic menopausal women, we understand there's endothelial dysfunction which may reduce genital blood flow. There's a component of neuropathy. So, neuropathy may impair the sensory response and arousal. Chronic hyperglycemia eventually results in microangiopathy, which may affect her sexual organs, as well as the psychological impact. The anxiety, depression, sleep disturbances, all of them have been shown to reduce libido and induce female sexual dysfunction. So, symptoms and signs of female sexual dysfunction, right from hypoactive sexual desire, the loss of desire for sex, inadequate vaginal lubrication before and during intercourse, inability to achieve orgasm, vaginismus, vulvodynia, or non coital sexual pain disorder are very common. So, when it comes to sexuality in diabetic menopausal women, it has multifaceted challenges, right from vaginal dryness as a result of estrogen loss, there's vaginal atrophy, dyspareunia, hyperglycemia also reduces hydration of the mucous membranes. So, therefore, the vaginal mucosa becomes dehydrated, again resulting in reduced libido and dyspareunia. There's genitourinary infections, and physical discomfort may lead to an avoidance of intimacy. And vaginismus, a condition that causes vaginal muscle spasms, can also make intimacy difficult. So it's not only her mood changes, it's the physiology which is causing all this female sexual dysfunction as she's nearing menopause. So, like I said, effect of neuropathy, peripheral neuropathy may affect genital sensation, impair arousal, reducing pleasure, and making orgasm difficult. There are vascular complications. There are emotional and psychological dimensions as well. Like I said, relationship strain, loss of intimacy, depression, poor self esteem, anxiety, all of them are vastly undiscussed in clinical settings despite their profound effect on the quality of life of a menopausal woman with diabetes. So, what are the practical strategies? Number one, a proactive screening approach. So, I think it's important to screen menopausal diabetic women for sexual dysfunction using validated tools that are available today, such as the Female Sexual Function Index, a simple questionnaire that you can give to your patient sitting in front of you to evaluate her and probably screen her. A comprehensive assessment involving not only her glycemic control, look at her diabetic complications, her vascular status, neuropathy status, her hormonal status, and psychological well being. Of course, a good physical examination is mandatory, and of course, a review of all medications that may impact libido, arousal, or sexual dysfunction. Management strategies, again, like I said, a multidisciplinary approach is important, right from glycemic optimization, lifestyle, diet, exercise, weight management. Psychological support is very, very important. Counseling wherever it is necessary. Stress management, very important, integral component. Hormonal management. HRT is not for every woman undergoing menopause. So I think consider HRT only in selected patients where necessary, and of course pelvic floor therapy and drugs which may be present, maybe which may be prescribed. Medication adjustment again is very important. Reviewing and adjusting medications that may impair her sexual health is very important. Again, evaluation of cardiovascular risk, preventing infections, and reviewing drug interactions. Lifestyle becomes very, very important, and this is where you need to counsel on the need for regular physical activity, maintaining a good nutritional balance, healthy diet rich in fiber, vegetables, etc. Weight management is very important. Like I said, postmenopausal weight gain is a very common problem. So I think she needs to manage her weight, and this is where weight management strategies all kick in. And of course, like I said, enhanced monitoring, medication optimization, and discussion on hormone therapy becomes important. And psychosexual counseling and mental health support. Most of the symptoms we say, oh, she's menopausal, so she's got these symptoms. But I think it's important for her emotional well-being to actually take these symptoms seriously. If she needs counseling, that is where, as doctors, you can provide counseling, refer her to a psychologist or even a psychiatrist. There are support networks that are present today, both online as well as offline, where you can send her. And of course, seeking professional guidance as and when necessary for her better quality of life, because physical health and mental health are both interconnected, and this is the stage where she needs all that guidance that you can offer. So friends, it's important to break the silence around menopause and diabetes, because despite affecting all the women a stage in her life, she is going to undergo a menopausal transition. This is where the intersection of menopause and diabetes still remains shrouded in silence, because a woman sitting in front of you, you look at her diabetes management, you change her diabetes drugs and send her home without actually giving a second thought that a lot of this may be linked to her perimenopausal transitioning that is happening. So many women report feeling completely unprepared for the menopausal transition, because I think as physicians, as doctors, we need to set the conversation going, particularly on how menopausal transition may also affect her diabetes management. So, as healthcare providers, most of us lack training in this particular area, leaving women without adequate guidance during this very critical health transition period of her life. And this silence perpetuates suffering and missed opportunities for intervention. So, I would like to conclude by saying that it's important to integrate sexual health into diabetes and menopause care. It's important to recognize the problem, because sexual dysfunction is common but under recognized in menopausal women with diabetes. It's important to identify early and provide her a comprehensive management strategy, which may eventually improve her quality of life. It's open to encourage dialogue, communicate openly, and a multidisciplinary collaboration is important for holistic care of a woman with diabetes undergoing menopausal transition, and providing education and a tailored treatment plan addressing individual needs of each woman will eventually empower our patients and help them sail through a very difficult period of her reproductive as well as mental and physical health. Thank you so much. It's important to address sexual health, which is not optional today. It is an essential component of comprehensive diabetes and menopause care that profoundly impacts patient well being. Thank you so much.